All right, sounds good. This is Kristen Bunt from Sadaho, and I'm the Director of Quality Integration that most of you are likely familiar with. Jennifer Koch, our Improvement Advisor for our HIN hospitals. So thank you everybody for joining. It looks like we have a really good group attending. So we kind of will have a mix of potentially some CEOs, our quality contacts that often are the ones reaching out to Jennifer, as well as those that are submitting our data. So I'd like to welcome our speakers for today to help us kind of look at some of our data and some of our opportunities and just learn about more about our data as you guys are submitting it. So first I'd like to welcome our contacts at IHC, Iowa Healthcare Collaborative, is Jen Brockman. So she's the one that's you guys have likely heard or seen when you first got signed up for Compass HIN. And then we also have Kathy Trenton, who is our contact and our data guru with the Iowa Hospital Association as well. So with that, I will turn it over to you guys.
Thank you, Kristen. Good morning, everybody. This is Jen Brockman with Iowa Healthcare Collaborative. I'm the program director for the Compass HIN. Welcome to our virtual data workshop. We're going to hear a lot from Kathy Trenton today. We're going to talk about health equity and the real data, race, ethnicity, age, and language data that we collect from hospitals. We're going to talk a little bit about sampling methodologies and the reporting of meaningful data, and we're also going to talk about the value analysis that is now available within the Compass HIN database. Also, at the end, we're going to, I'm going to take some time to do an overview of the HIN 2.0 results for the IHC HIN, as well as HIN-wide, so across all HINs, including the HRAT HIN or HIN that you guys were previously part of, and talk about their results. And then I'm going to talk a little bit about our current HIN results for Compass and where we currently stand across our entire network. So I am going to go ahead and hand things over to Kathy Trenton well, first, a couple housekeeping items. I have muted all the lines. You do have the ability to unmute your line if you have a question. If you don't feel comfortable speaking or would rather, the chat box is also available. You can type your questions into the chat box and we'll make sure that we get to those throughout today's session. And also, I'm going to offer some time for question and answer. We really want this to be interactive. You don't have to limit your questions to just things that we're covering within the PowerPoint slides today. If you have other questions related to your data entry, the database, anything with the Compass HIN and the work that you're currently doing, please feel free to raise your hand, type a question in the chat box, or go ahead and speak up. Now is a great time. You have Kathy on the line, and I'm on the line, Kristen and Jennifer on the line. So you have a captive audience, and we're here and able to answer those questions for you. So I'm going to go ahead now and hand it over to Kathy Trenton. Kathy?
Thank you, Jenny. I welcome the opportunity to share some information today. Excuse me. I have to clear my throat. I haven't talked a lot today. Know that the Compass HIN has done some regional meetings with Iowa hospitals, and so today is one of 4 regional meetings. This one is virtual, and we have shared the same information at all of these. The feedback that we've gotten and questions that we've gotten will be valuable to us as we move forward in this very important work. I want to recognize Jenny Brockman at the Iowa Healthcare Collaborative and Kristen and Jennifer at Sadaho for all of the work that they do to bring resources to you in your data collection, data gathering, understanding data. We realize the burden and the responsibility that goes with this added, but we hope there's value added information that you can get out. Everyone comes to a meeting with an idea about something that they would like to learn. Today, you're going to hear a couple of ideas that for data uses. We aren't going to get very specific to each hospital, but if you have burning questions that you want help with, definitely reach out to Jennifer and pose those questions. Sometimes if we don't know the answer, we're able to elevate that to those parties that do know. So with that, I would like to just talk about what we call real data and give an understanding of some of the work that's being done with the information that your hospitals are currently submitting. So Jenny, can you advance slide? So these first slides actually just make a case for the research that has been done on how important these kinds of data are. And before I get too far into it, some people would say, how do we know what your race, ethnicity, age, and language are? So these are fields that are submitted with your claims data that each hospital in South Dakota submits, so that Sadaho has a database that we can analyze record level information and look at trends. It is the source for the statewide database, is your source for the 50-some measures in hand. Nearly 24, 25 come out of that database. So when you get a monthly update, you see your point in time information. If anyone has questions about what that process is or how that happens, please, we can go into that a little bit. But for today, I'm going to not focus on that, but talk about the use case for this data. We recognize that there are disparities. There are things that happen in our cultures, knowingly, consciously and unconsciously. Getting to know patients and knowing your community needs are becoming buzzwords, but having the ability to understand your community and engage with the population that that come in your doors of your hospitals is an important part of the work that is being done. So you can go on, Jen. I'm not going to read these. Obviously, you're welcome to read the quotes that you're seeing. This is I just am going to point out here that for the disparate populations that might be in your communities, it's also, there's been quite a lot of research that ties these chronic illnesses to that subset of your patients. And so having access to care and access to quality care for all patients is obviously the goal for everybody. So if you could go on, Jen. Here's another, I talked about unconscious racism, and I don't know anyone's tendencies. I think that we would all agree giving all of our patients quality care is a priority. So whether we knowingly or unknowingly discriminate, it is a reality, and making yourself aware of it is probably the biggest hurdle that has to be gone through. So you can go on. So for today, for this first presentation, we're going to look at an overview of health equity, health disparities, and some social determinants of health that impact the care or our delivery processes. And we'll describe what the real data is. You'll see some examples of the Compass in real analysis that has been underway, and then we'll talk about how we're going to use these data for sharing with hospitals. And I know that if we were face-to-face, this is a much easier question to ask, but if you've never heard of health equity, I guess we can talk about it, but real data is, this might be the first time you're hearing those kind of acronym terms. So we're hoping that you come away with an understanding of what it is, what it looks like, and how you can use it. Attainment of the highest level of health for all people. Health equity means efforts to ensure that all people have full and equal access to opportunities that enable them to lead healthy lives. I've already touched on this. I think we can agree that that's the goal for everyone. What are disparities? Disparities are the differences in health outcomes, and when those are analyzed in this light, because if you have a subset of your population and the outcomes, maybe you think the care that you're giving this entire population is the same, but when the outcomes for a subset of your patients is different, it could lend itself to to a deeper dive in your hospitals to analyze what's happening with those. The social determinants of health are those factors that influence that. It's the 360 picture. So next, Jen. This is a graphic way to look at a patient. So the core or the middle are those things that the patient brings to whatever they do. You know, this is applicable to the grocery store as much as it is to the hospital. So the core part of that patient is represented by blue in the middle. Those things that influence that patient and that consumer are on the outside. And so there are many things, backgrounds, living conditions, what their education level. And so the outside of the wheel graphically depicts the influences that that patient brings to their experience. So why do we even do this? We've already seen the documentation that it is recognized as a national problem. I don't know if you're aware, but the Agency for Healthcare Research and Quality, or AHRQ, has for years done a disparities report that focuses attention on maybe things that we're not so used to in Iowa and South Dakota for large urban centers. We don't have that influence. So, you know, some of us live in larger cities or towns, but we have a very rural influence. So what does that mean for Iowa and South Dakota? There is also much research that says when these disparities or different outcomes for this subset of people leads to increased costs. And finally, the population demographics are constantly changing. So what would be true 5 years ago continually needs to be analyzed. So that's what this will be a step toward that. And this is more of the same. Disparities lead to more medical errors, longer hospital stays, readmissions potentially, over or under utilization. So those are all the research clearly supports that we should take a peek at this. So what is real data? If you want to go into it, Jen, that'd be great. Okay. REAL stands for race, ethnicity, age, and language. Now, these could be things that you were not even aware of, that they were included in what is coming with your claim. On a claim, the typical claim that goes from a hospital to a payer actually does not have race and ethnicity as fields that would be in that transaction. For Sadaho, though, they've had a lot of foresight to ensure that they're collecting as close to accurate information about race and ethnicity through a value-added way to submit that. And for age, obviously, that is a determinant because we get the date of birth. For language, there's a story there. We currently do not collect language, so that while we talk about real data and it is underway, we've talked about adding language. There's a decision-making process that has to happen for that to be included, but we'll see what happens in the future for that. So some internal reasons. So if you're in the hospital, what does this mean for you? Because you could say we have a very homogeneous community, very rural, but you still, if you analyze people traveling through your communities and things like that, you might be surprised at the findings. So we do want to identify differences in care so that targeted interventions can happen. You are constantly being made aware through community needs assessments that you're supposed to be, hospitals are well positioned to be the leaders in their communities because of the history of reporting data, the history of interacting with your entire community. So those health community problems that happen can be addressed more effectively if you're aware of what that is. So it's also true that if you link this race information to quality measures, you can get to what you need to look at and then intervene if that's necessary. I know that many of you already engage with interpreter services. You have patient materials that are multilingual, and you probably do the cultural competency for your staff. So these are interventions that help you understand what your community is and then bring them the things that are necessary. So the results of REAL help improve discharge planning. This is something that you could incorporate into that process. Culturing tailored patient care and education plans. If you understand your patients better, then the tools and the resources that you use will help their outcomes, so that readmissions and you know, continued health or improved health are what happen for that person as well. You can develop interventions to reduce the disparities so that outcomes are equal, and you want good outcomes, obviously. And if you use data for real data in the operational and strategic decision making, it could be something that is shared with your boards to keep them informed on the work in this area. So one of the directives that CMS has provided to all HINs is that this is an analysis that is part of the work that is required if you are an HIN contractor. So how do we have to standardize that work? We use real data to identify the differences in the outcomes, and then we leverage real to drive down areas of harm. So standardizing, what does that really mean? Currently, all Iowa and South Dakota hospitals submit these data, and I've kind of explained to it. If someone has a question, please jot that down or bring it up as we're talking. At the question and answer period, I'd be happy to get into this more, but I want to make sure that you understand that there is a way to gather it. And then in the current collection, language is not completed, not currently collected. In the Iowa, we are actually working toward our Council on Health Information that guides the Iowa Hospital Association in our data work, gave us permission in May, this past spring, to undertake a format change. We rarely do a format change, but we have permission from the council because of the importance of gathering this new data field. We're looking at adding it in the Iowa collection, and we're hoping we've introduced the idea to SEDAHO, and that decision-making process is still underway. These next few slides, I'm not going to read them, but you can get a flavor for what is collected on that claim. At the claim level, we ask that the race be reported with these numeric or alphanumeric numbers here. So R1 is white. These definitions come from the Office of Management and Budget. They're federally standardized, and we apply them for in the hospital collections. If any of you are familiar with meaningful use, race, ethnicity, and language are included in that, to be able to include them on your data collection, etc. So if you go on to the next slide, Jen, this list continues for the race. We do, in Iowa, we share a, how do you collect this in your registration departments? And I've been around a long time, and in the past, at some points, it's also been, I've heard it all the way from registration staff that say, we can't ask that question, that you just can't do that, all the way to where a judgment is made by the registrant to assign the race and ethnicity without asking the patient. And so those are kinds of things that we hopefully can train our staff to ask questions in a patient-centered way, so that the patient actually provides the information and it isn't a judgment by a staff person. So if you go on to the next one, the ethnicities are, oh, I guess it's coming up. Sorry, I thought that was the next slide. So real data helps to identify differences in the health outcomes. We've talked about that. So what is the next step? And I'm going to let Jen just weigh in here, because the real dashboards, do you want to just weigh in here, Jen, about what the plan is there?
Sure. So we are currently working, or the data team is working on development of some hospital specific, so there'll be individualized dashboards that will eventually be available within the reporting database based on the real data that is collected from your hospital. I don't really have a timeline yet. We're in the process. We've run into a couple hangups, but we are working on that, so you'll have that to look forward to in the future.
Thank you. The value add that we do to analyze some of the outcomes, because we have the record level, we can analyze what that patient is there for. So DRG and principal diagnosis can be tapped into, and they help do specific studies. And we're going to have an example of that coming up. You can go on, Jen. So here is the data. This is what the HIN actually shows right now. So for January to November of 2016 data, the count of patients, 19,921 patients. It shows you the distribution of the races that are collected on the claims data. 90% being white, all the way down to multiracial at 0.3. Something that if we did a slice of South Dakota alone, it would be interesting. I think might be something we want to consider adding to the analysis, Jen. I'm just making a point because I think that there would be an influence in South Dakota that could be different than what Iowa shows here. But for this is Iowa and South Dakota data together. You can go on. So in the ethnicity field, we collect Hispanic or non-Hispanic, and you see that population there. I thought actually was quite surprised that it was only 1.5% Hispanic in our databases. But it surprises me a little bit. A pretty even distribution for gender, though. So. The analysis that you're seeing happens to be in the readmissions area. So how we're applying real data to the outcome of readmissions, who gets readmitted more often. And in this case, if there were the rate column is where I would like you to focus. So 12.91 per 100 admissions that end up being readmissions are from the white, from 93% of the readmissions. So what kind of surprised me here is it starts to show that the African American or Black category has a significantly higher rate, and so I just find that to be quite interesting, even though they're only 3.12% of the readmissions. The rate per for that category is quite high. And then in the ethnicity, we are decidedly in the non-Hispanic or it should be non-Latino there. So obviously that rate is quite high. So what does this all mean? Again, this is Iowa and South Dakota data commingled. Oh, wait a second. I totally just read the title, and I said that we add DRG and diagnosis. So this is a cut of readmission data when sepsis is the reason that that readmission is happening. So again, we can apply targeted interventions in this area when we know that there is a potential for one of these outcomes to be different in a set of race or ethnicity. Thanks, Jen. You can go forward. So again, this is sepsis in the area for gender and age groups, all of which can, what really stood out to me if I look at this in the age groups of the 45 to 54, that rate ends up being quite high. That surprised me. It could be that the number of, obviously there are fewer hospital stays for some of those younger ages, and I just thought it was interesting that the rate for that age category was decidedly higher. So we're getting close to a stopping point when you can ask questions. So please jot them down, or we'll make sure that we get everyone's specific questions answered here. So what do we do with this now? We are expanding our focus on that. The Compass HIN has engaged Dr. Kirk Phillips. He is a PhD and a statistician, and he is doing this work for us. Very knowledgeable, very research-based individual who is helping us delve into this and analyze it. So these dashboards will be what are the end of his initial analysis, and then we'll make it so that it's repeatable. And so let's say that in a year from now, we're analyzing it continually. All the data are refreshed every month, and so that's a continual process. It isn't something we do at once and then don't look at it again. So your improvement advisors are the technical assistants, and when you do receive some of this information, excuse me, it will be key for you to reach out to them with any questions. The goal is to reduce the cost, reduce the disparate outcomes, avoid readmissions. If you're a PPS hospital, you are impacted by the readmission reduction program. So obviously, it can affect your bottom line. But probably the biggest thing on here is to improve the population health. So. Jen, this would be a good time. Collecting race and ethnicity is something that we give credit to HRET. They have developed some training tools for registration staff, so we're just giving credit to them for some of the things that we share routinely. Are there any questions?
I am going to go ahead and unmute the lines and see how we do with this. Again, to try to cut back on the background noise, if you guys will mute your own line if you don't have questions or comments, that would be incredibly helpful. So let me go ahead and unmute.
I was just going to say, trying to say new.
Yes, if you don't mind making the copies.
Yeah, I shall do that.
All right, so all lines are unmuted. So please feel free to go ahead and ask any questions, or if you have any comments for Kathy.
I must have done a really good job.
All right, so we will go ahead and move on to the next presentation here, which is the HIN value analysis. And I'm going to go ahead and mute the lines again. All right. So here I'm going to let Kathy talk a little bit about the value analysis and the value estimates, and I'll jump in where you need, Kathy. The value estimates are something new with HIN. It's something that we have always tracked with our HIN hospitals previously, but something that is available to our HIN hospitals on demand within the database in the dashboard. So, Kathy?
Sure. This has been a challenge, as Jenny just mentioned. We continually hear from, especially from the CEO level, what is my contribution to the 2012 20% reduction in harm and 12% reduction in readmissions? What's my hospital's contribution to those numbers that are available? You'll see Jenny's going to share at the end of the program today. Jenny will share the Iowa picture and the nationwide picture for some of these value analysis things. But this question that we continually got asked happened to be important enough that we have now incorporated it into a on-demand report that you can run within the database collection tool. So if you want to go on to the next slide, we're going to just talk about how we came up with the report that you will see and how you can interpret it. So we're going to look at how we arrived at that. We'll discuss obviously the Compass HIN goals and how we, what method did we use to assign a value, and then show you examples of the HIN dashboard. So we needed a way to show value for the HIN. In the early years of HIN, we were challenged to provide to, at that time, the Innovation Center, a way that we could prove that we were having success at reducing readmissions and reducing harm. So the way to show CMS are what we were challenged to do, and how we're going to, if you want to go on to the next slide, Jen, this was the path that we took to get there. So for the HIN, now I realize that South Dakota was actually part of RHET. You would have seen these numbers at a larger level because they had more hospitals, but number of harms avoided, the lives saved, and any cost savings, those are three of the areas we look at. We there's a lot of outcome measures you could analyze, decreased lengths of stay, decreased patient days. So some of those are what we analyze when we look at a baseline period against the current performance. So for the Compass HIN, the proposed impacts are displayed here. Obviously, we want to get to the bottom, the proposed harms avoided of nearly 2,500, 23 lives saved, and then nearly just over $29 million saved. So, Jen, do you have the year 1 and year 2? I meant to ask Ellen, are those actual numbers of our performance to date?
I have the year 1 or the HIN 1.0 and HIN 2.0 breakdown. Oh, I'm sorry. No, these are our goals. So these specifically are goals that we have proposed to CMS for our network.
And so the total at the bottom are combined year 1 and 2.
Correct.
Okay. Okay. I didn't want to misstate what that they aren't the actual numbers yet. You're going to show those later, right?
Absolutely.
Okay. Thanks. And can you advance the slide? So how did we do this? Again, a lot of research and literature mining happened. We set up a baseline period with a as the pre-test, and then the post-test would be our performance or outcome period. For any one hospital, if you have at least 1 month within both of those timeframes, both in the baseline period and then the evaluation period, if you have at least 1 month, preferably we would want all the months, but if you have at least that, then your hospital would have been included in the value for the Compass HIN at that level. The formulas for the calculation are available here, and these slides will be shared so that when you do go to the program and run your own value analysis, you're going to be able to determine, use the formulas here if that is what you desire to do. So obviously the top 2 lines, you come up with a baseline rate, you come up with your evaluation rate, you do the mathematical formula that are in the bottom 2, and you get expected events, and then what you expect and what actually occurred ends up giving you what you avoid. And I hope nobody has questions about those, but please ask them if you do. So this is an example of what that literature research gives us. So if for each measure, there is, if you avoid one event, there is a literature research that says this is what that means in dollars and in patient days and in mortality or lack or improvement in mortality. So when one event happens and the literature says that saves $1,000, then avoiding that event credits your hospital with that $1,000 in savings. Here's another example where, and this is more common than you would think, but where the research gives maybe a wide range of results. Like in this case, the estimate is at the $10,000 on the low end or $15,000 at the high end. And so where research shows that this is the value or the estimate for this, we average those multiple resources or sources, and then use the average of those to determine what that savings are in this case. So in this case, one event meant $12,600 savings. It is important to know that they're not actual costs. Obviously, this is not something that you can say that you saved your hospital this amount. Hospitals, you'll see, when you see your own results, it will be totals. It won't be at the individual level by measure. There will be a way for you to get to some of this, and that is what we're going to want to walk through that here pretty soon. Contact your improvement advisor if you want to see those individual results. So, by measure, what you're going to see is your entire, all the measures lumped into one. These are some other things. If you're a statistician, the inflation are taken into account, direct and indirect costs. I'm not a CFO, but if there are any on the line, some of this would be meaningful, could be meaningful to you. Where there are specific definitions for each event, it could be that the documentation or the literature search doesn't get to the exact type of harm avoided, but it's you can make a case that you can apply that dollar amount or count of events avoided because it's related, not directly called out for that type of event. So can you go on, Jen? These are the measures that are included in the report for the report will be at your hospital level. So these are the measures that are included in that calculation. So any event or dollars or lives saved in any one of these areas are aggregated for the report. And so if you go on, Jen, I think this is exactly what you will see if you run this hospital-specific report. The facility value estimates are analyzed for, again, your baseline period and your evaluation period. You come up with your events avoided. The literature for each measure says what that savings is. And so events avoided, excess cost avoided, excess length of stay avoided, and excess mortality avoided are what the report shows you. This is your contribution to the Compass HIN and obviously to the entire HIN network. There is a disclaimer on here that is we're going to talk about next. And so you go on to the next one, Jen. This is the disclaimer that is included in each report. Jenny, do you want to talk about this a little bit and tell the thought process that went into having this be on the report? Because didn't CMS make us do this? Okay.
Yes. So this was a requirement from CMS that we include this within the value estimates. We just wanted to make hospitals aware that the value estimates that are included within the dashboard are exactly that. They're estimates. So we ask that hospitals, you can share them internally, but we do ask that hospitals not publish this because again, it is for general informational purposes only, so you can monitor your direction and how it's affecting those length of stay, your cost incurred or saved. But it is very much just estimates based on literature. And so we didn't want hospitals to publish it in their local paper and say, you know, we saved $5 million because of the work that we've done, or whatever it may be, because again, they are just estimates.
Thank you, Jenny.
Kathy, there is a question here quick. Could you clarify positive and negative value estimates?
Sure. When the calculations are done, it could be that you didn't avoid any events. In fact, maybe your events are going in the wrong direction, and you're having more of them from when you compare your evaluation period with your baseline. So if you had, let's just say, you had a readmission rate of 8% in the baseline period, and now your readmission rate is 10, you're going in the wrong direction. That would be a negative impact. The positive impact are lives saved, dollars saved, patient days avoided in length of stay, and events, the number of events. So if you have a negative number, it means that you're going in the opposite direction from the desired. And if that still is not clear, I'd be happy to, we can discuss that here coming up. At this point, when we were in person, we actually had reports, a sample dashboard. I'm going to encourage you to go out and generate the one that is in the program right now. It will give you your facility's numbers in the value area. Please reach out to Jennifer or Kristen if that has brings up questions for you. It does help focus you on areas that could be impacting the value analysis in a positive or in a negative way. So I'd like to open it up for questions if there are some.
I'm going to go ahead and bring up a dashboard here so we can walk through it.
Yeah. So for each measure that were on that slide, the measure itself has a display. So when we get to the bottom of the page, you're going to see the named baseline period and the named evaluation period, but each of the measures shows the result for in a conditionally formatted way for what your hospital's contribution is to the total picture of value. So the improvement rate is obviously in a green for the ADE rate. It shows your facility rate compared to the peer group, and then the HIN average with a run chart that shows your performance. And it isn't showing the lines on here, but believe me, they're there. So if you glance down, and Jen, if you go down a little bit, in this case, the emergency room department catheterization has a yellow conditionally formatted number. Areas that are blank mean that you're not reporting that measure. And so the time frame for this is for the evaluation period in this case was January. Actually, is it, if you go down, I think I thought that there was another line.
No, so the time frame here that was pulled for this specific dashboard is January 2014 to December 2016.
Okay.
I do want to make one note about that for you guys when you're out there populating your dashboards. I really would discourage you from looking at any more than a 6-month time period within these dashboards. If you go greater than the 3 or 6 month time period, it could really affect your percent improvement. Keep in mind that percent improvement is baseline. It takes your baseline data compared to whatever performance period you choose to populate for the dashboard. So it looks at your improvement specifically for that performance period. So a good example is if you pull an entire year's time, 12 months time period, and maybe your rates for a specific measure were higher, your performance was not as great at the beginning of that 12-month time period. Even if you did see considerable improvement during that 12-month time period, those rates, those monthly rates at the beginning of that 12-month time period is going to affect that overall improvement rate that you see in this first column here. So again, I would really encourage you just to look at 3 or 6 months at the very, very most.
That's a really good point. And I want to clarify something that I think I misspoke on. Can you go down to the value analysis at the bottom?
Mm-hmm.
I think I misspoke earlier on the positive and negative. So in this case, excess length of stay avoided is a negative number, where if you're going in the opposite direction, you're adding events or costs, that's a positive number. And I think I said that in the reverse earlier. So the key to that would be to read what the header says there, and I didn't do that until now. So
This is Kristen. Can I just add a couple of comments in just for
absolutely.
our hospital? So one thing to keep in mind is that for the South Dakota hospitals, some of the data is delayed in coming over into the CEO or into the dashboard reports. So when you're taking a look at the dashboards, it may appear that there isn't as much data in there. There's a couple of reasons for that. Obviously, our transition from HRET HEN into HIN with Iowa, that has a lag in the data that we've reported in the past. We're taking a look at that, and Iowa is helping us look at historical data that had been entered in HRET's HEN database to help with that. Additionally, we had some issues with NHSN too, so in getting our facilities to confer rights. So some of that data isn't coming over into the dashboards as of yet. Also, just because of the ruralness of our South Dakota facilities, in Iowa is the same. However, they just have they've been reporting for longer. The volumes that are listed in there, so running the 6 months, most of our facilities had started entering data in December or January, so there's a lag there as well, just to get that data pulled and entered into the database. The claims data that we submit, that data has gone back for years, and so the data that, or the measures that would be reported via the claims data, that is populating in there. So I just want to clarify, and if there's questions, please do ask when you're taking a look at your dashboards. because we don't want to make it just out there that performance may be lacking or is there. It might just be an issue of data entry, etc. So
that's a really good point, Kristen. And two, that is something that I actually am working on right now, to where we can find a HRET measure that matches with one of the Compass HIN measures. We are taking a look at adding either the baseline and or other months into the SQL database, so that you will probably start seeing some results where in the past, the thing is that some of these measures, the Compass HIN was required to create a 2014 baseline. So where you don't, if we don't have that 24 baseline, then you're not going to get a result either, because you need to be in both the baseline and in the evaluation period. Like I said, I'm doing that exact thing right now. I worked on it yesterday and today. We're working to get it into the database, and we'll just make a point to reach out to you, Kristen and Jennifer, to let you know when your hospitals could start to see some of that historic information where the reporting will be enhanced.
yeah, that'll be great. And one thing to note is the difference in measures. So, and Kathy mentioned that they're trying to match up some of the HRET measures with the Compass HIN measures. So, I just want to make sure that people understand that if the data goes in and it doesn't look exactly like you had anticipated, that there is still the opportunity to relook at that to see how the data had matched up with HRET and the Compass HIN data, because we want to recognize that there might have been some differences in how data was collected with HRET versus the way it is now, which I feel with our relationship with Iowa and that database, that there's more structure around the measures than potentially there was with HRET. And so we just want to make sure that that people recognize there might be a difference in there, and it just kind of if you notice something, we want you to bring that forward so we can take a look at it and have a discussion about that. So more to come, as Kathy said, when we start to look at that 2014 existing data. So
absolutely. And we really almost, we need your feedback on this. We make these decisions for the community, for the entire HIN-wide hospital network, and we try to do the standardization and normalizing data and things like that. We do need your feedback if you see something that is different than what you would expect, though. So that would be key for us to make database improvements and changes that reflect what your hospital activity is. Are there any other questions about this, about that report? And of course, if we do this historic data and you still don't see anything, we might want to work with Jennifer on how could you collect some of that baseline data. It's mostly baseline data that we're missing. And so how could we work together to get something in there for that period so that you can have representation in both the baseline period and the evaluation period?
All right. Any additional comments or questions about the dashboard? All right. I'm going to go ahead and close that out. I'm going to go ahead and open the line and offer an opportunity for comments or questions from anybody that's participating today.
And so she's like, the only reason I forgot it is I forgot to change the number once, and boy, did I have to hear it. She even
Are there any
right.
comments or questions?
All right, we'll move on to the next presentation, which is talking about the overview of data collection and sampling methods. And Kathy, within this presentation, I don't have any slides in there. I don't think about POA or anything that might be more specific to the South Dakota hospitals. So if you get a chance to include those in there, that would be fantastic.
Absolutely.
All right.
Keep me honest, and I'll try to incorporate the POA talk because I think that is of utmost importance at this point. So for all HIN work, I need to say a huge thank you and data, etc. Obviously, we say the words that we'd like to minimize the work that goes there so that we can optimize data analysis and the work that goes to improvement. So where it is possible, we try to provide suggestions or ways that could help in the data gathering, where those self-reported measures require a chart review, some kind of observations, and those kinds of things. Are there easier ways that could make your life a lot better? You know, so today this is going to be just a quick overview of some sampling methodologies that might be applicable. If you have a question about this, please reach out to Jennifer, and she's going to be a good resource to bounce ideas off of. So the successful data collection plan should include the things that are on the screen right now. You need to determine the who, what, when, where, why, and how. Where possible, use those internal resources, your electronic health record, your pharmacy report, the registers, where you can gain something point in time in an electronic way, run a report so that you get your aggregate numerator, denominator. Those are the things that we're looking at tapping into. When we design the measures, we take into account what is the lift to gather this, because some things in the past have proven to be really cumbersome to do in a monthly data gathering. So for those external sources, we will continue to tap into those if that is, if it proves that it can demonstrate improvement in the focus areas that we're working on right now. So choose this sampling methodology where it's possible. There's a list of measures in here where we even suggest sampling rather than doing a full out count every widget idea. Yeah, if there is if you have the capability, train somebody to have a job in your hospital that they will need the expertise to understand what they're collecting and why, and what applies to, say, a denominator like observations versus how many times a numerator case, how many times did they wash their hands, so things like that. So delegate the responsibilities where you can, involve those other units that are impacted for the measures. I already mentioned pharmacy once. Involve them in the work that you do for ADEs. And so wherever we can, we try to encourage the easy button. And I know that it isn't an easy button. So can you go on, Jen? So a population is just that. That's the denominator. Population and denominator for what we're talking about are synonymous. So the aggregate or the group. Determining what your denominator is it'll be key to familiarize yourself with each of the measures so that when you're doing your data collection, you're examining results for the preset or predefined population. Sampling allows you to pick a portion of that population to analyze what results, or the numerator in this case. So if you're counting widgets, and widgets with red on them are the numerator, find a sampling methodology that allows you to not have to look at hundreds and hundreds and hundreds of population, or the aggregate in the bottom, and the denominator. So can you go on? So obviously this is should be very clear. Improvement's the goal, not data collection. We want the focus to be on providing time for you to analyze your reports that show you I have an opportunity to fix something. Sampling should provide a logical way and make the time for data collection smaller. And then the conclusions that you'll draw should be representative of the entire population. So how do we do this? So we'll get into some examples here. Again, sampling will save the time and resources. Your sample should be representative of the whole, and we do recommend 15 to 20% of your population. So if the denominator, an example here, if the denominator are patient days, and 15 to 20% of the patient days are what you're going to analyze for, let's say, for your VTE process measures. Pick the amount of 15 to 20% of whatever that denominator is, and if it's you apply a sampling methodology, you're going to look at every 5th event, or that's just an example, but in some systematic and organized way, sampling should tell you the picture of that and of your hospital performance for that. So. There are 2 types of sampling that are talked about here, the probability and non-probability. So in the top one, every element in the population has an equal or random chance of being selected. it'd be like putting names in a hat and drawing one out. So in the non-probability sampling, it is not possible to estimate the probability that every element has been included. So you don't have an organized way of doing it, and there's no way that you could, you wouldn't be able to defend that your results might have included all the good cases and not included, and you avoided the bad outcomes. So can you go on, Jen? Is this available to them, Jenny?
Yes, all the slides from today will be available on Hinnovation, as well as the recording once we have it transcribed.
But isn't this a specific, the slide, isn't there a specific document or a PDF or something that we have out there?
Yeah, and I can make sure that that gets posted as well.
Yeah, okay, so this is a good tool when you're doing these, what type of sampling do I want to do? So the population obviously is at the top. A random sample, you just pick names out of a hat, pick charts off the shelf, you pick charts out of a stack, you pick, if you're on this unit, you pick every third room, or something like, or that would actually be in the middle one, systematic. So if you're on the unit and you're going to observe every third room, every third patient room for whatever you're observing for that day. And so that would be the systematic. And then in stratified, you would separate into groups. So if you know that you have in your population, you have a variety of, maybe we'll incorporate real here, age could be a good way to stratify, race, severity of illness would be another one. So you stratify into groups, and then you sample, or within those groups, you take the same count from each area. So this is a good resource to even pin on by your desk so that you're looking at it all the time. I think, did something pop up in the chat?
No, Kathy, nothing in the chat.
Oh, okay, okay. If you can go on, Jen. Okay. Here are I talked about this a little bit. Just random means there's no organization. You draw out of a hat. You pick patients with the last name of A, that start with A. So there's a lot of things that go into a random sample. There's no organization here, but there could be some measures where random sampling fits the bill for you. So maybe it's what charts are available at that point. The systematic sampling is detailed here. Every 5th patient, you're going to do the same thing to every 5th patient. And so if you're, let's say that it's number of discharges are your denominator, you have a month's worth of charts sitting in front of you. You pick every 5th chart. That would be an example of systematic. And then the last one would be if you go on, stratified. So we talked a lot, I already kind of put this into an example, but this would be a good resource. The slide would be a good resource. There are a number of things that you can stratify by, and the examples are given here. Patients in certain areas, if you have different units that you evaluate, you'd pick 3 from each unit. and then within the unit, you do some kind of organized way to say which case are you going to look at, which room are you going to look at, etc. So you can go on, Jen. In this case, this cluster, as it reads, the population is divided into groups or clusters. It's like the systematic structured sample, but then do a random pick within those. Take all your hospitals, divide them into individual hospitals, and draw randomly. So there's a lot of combinations that you can do when you stratify something in. You'll just want to represent in your sample. You simply want to represent your entire population, and not. So if your entire population is 60 people older than 60, and you ignore the 40-year-olds, then you're not representing your entire hospital's population. I'm not sure if that was a good example or not, but you can go on. We talked about the sample size, the 15 to 20%, depending on the measure and what that denominator definition is. Obviously, when you have things like patient days, when the numbers get to be really big, how you determine what that size of your sample is. Obviously, larger samples will be more representative of your facility's outcomes, but that is something you have to weigh against the time to do the data collection. Some tips and tricks. Be consistent from 1 month to the next. Because one of the beauties of this data collection is that you get to see your hospital's progress from month to month. Make sure that your selection of sampling is the same and stays the same for the coming months. This is a really good trick. If you go on to the next slide, if you make notes, I think the next slide, Jen, will show on the actual data entry page, there's a place for the intervention. If you want to note what your sampling methodology is here, it would be there for you to see the next time you come in, so that you don't have to find the paper that you wrote on last month, or go to a computer file to find something. It would be right here. Take advantage of that place to write yourself a note. So that's a good tip. You can go on. So here, these next slides represent the measures where we suggest that you do a sample. So for the most part, you're going to notice that they are the process measures, and they're the obvious ones. If you have questions about this, please reach out to Jennifer, and if you have others that you consider would be eligible or should be eligible, we're open to suggestions there too. I think the next slide will continue. Again, these are the process measures for the most part. So for the one that you pick, we're going to want you to minimize the data collection time and optimize your improvement time. Data analytics and improvement should be the goal. I think you can go on, Jen. Again, this wraps up the process measures continue. Here are some tools that you could use, and I'm not going to read them, but they're included on the slides so that you can use this PowerPoint as a resource. There are tools that are available out there. Again, reach out to Jennifer, and if you have a question about a tool, if it applies or it doesn't apply, or if you have something you'd like to share and you think it's a good way to do data collection, you know, where you just make hash marks whenever something should be numerator and denominator. If there's an easy way to aggregate your sampling results, that would be, please share those. These are tools that are out there for validity, reliability, sensitivity, specificity that could come into play, and you want it to be usable and repeatable. And that is sampling. Strongly urge you to take advantage of that. Strongly urge you to work with your IT systems and your pharmacies to run reports where you can, so that it's not your time in data collection. If there are suggestions about how to improve the data reporting, the tool itself, the data collection tool, we would love to hear those as well. Are there questions?
Nothing in the chat. I'm going to go ahead and unmute lines. All right, all lines are unmuted. Do we have any questions or comments or anything that Kathy's covered so far this morning? All right. Kathy, did you want to talk a little bit about
Yeah, POA.
POA?
Yeah, sure. Another hat that I wear here at the Hospital Association is I oversee the state data collection, and I work with SEDAHO closely on the data validity and completeness. So in that role, we had an opportunity earlier this year to visit. We came up and did a regional meeting for those persons in the state that submit the data for the claims. And so that opportunity opened up the door to some discussion. One of the things that we're finding with, and that would like to suggest, is that the quality people in each facility work with the person or persons that submit that state data, encourage for the rural population. I think we all know that critical access hospitals are not required to include present on admission coding for their Medicare claims, and depending on which payers they have to interact with, some might require, some might not. So in the decision to add the POA code to any claims data is a hospital by hospital decision. For the state data, it's something that SEDAHO feels quite strongly about and encouraging people to include it. So what does it mean if it's included? Well, in the analysis that are done on all the claims data, the measures that come out of that database, present on admission impacts how the ARC grouper analyzes the numerator cases. If you have a pressure ulcer code on a claim and it is present on admission, that is not a numerator case for you. If that pressure ulcer code is on a claim and the present on admission code says no, this was not present on admission, it would be included. So you can see that in order to have accurate and complete data, present on admission impacts the ARC grouper. In a similar way, the Falls hack measure that we currently use, there are a list of codes that CMS call fractures and dislocations. And again, those have to be not present on admission in order to be counted in the numerator. Now, obviously, not including them makes you look really good, but does it tell the picture about hospital performance? And so we strongly are encouraging inclusion of POA by all hospitals, including critical access. In the current version, SDAHO does not require critical access hospitals to submit present on admission to the state data, but it is asking for it on a voluntary basis. So if there are any questions, I'd be happy to field those. Working with the people that submit the data, we strongly encourage them to reach out to the quality people as well and work hand in hand to submit. The other thing would be to submit on a monthly basis. The timeline for SDAHO does not say that you have to do that monthly, but from a quality perspective for HIN work, there's a lot of value in providing a more real-time picture for your hospital performance if you're submitting monthly. I'd be happy to field questions on either POA or monthly reporting. And I would like to open it up. Kristen, Jennifer, do you have anything that you'd like to add there? Oh. I talk in acronyms too. I want to make sure that everyone understands POA stands for present on admission. And it is an alpha character assigned to every diagnosis code that says it was yes, present on admission, no, not present on admission, whether it was clinically undetermined or unable to be determined. There are different alpha characters that represent whether that condition was present or not.
Thanks, Kathy. That was helpful to go over and explain. As far as POA, I think one of the areas that we hear is that it's not required for critical access. But again, this is something new for several of our hospitals in using claims-based data, and so the more frequency of data submission will help get a better picture and help you to drive towards improvement. It'll also reduce those manual reviews, and so we really want to get away from those areas that we don't have to go out and do an audit, that we can use claims data more often. So those that are on the call that are either CEOs or are the actual data submitters, we really strongly encourage, while SDAHO doesn't require that, again, it's beneficial because of the quality improvement aspect as well as POA. So Jennifer just is asking how do hospitals start to submit POA and that process, so they understand.
I'll be happy to help with that. When your hospitals submit the data to SDAHO in the claim collection platform. Present on admission is a field that is attached to each diagnosis code. If there is a desire to make a change to how that hospital is including or not including that, I'd be happy to help SDAHO field questions on how to change the file submission to include them. Sheena Thomas at SDAHO would be probably the contact to start with. She would elevate the question to IHA if we need to help connect the dots. We'd be happy to help.
Thanks, Kathy. And one thing I just want to ensure, and I know when Jennifer is out, she's reinforcing, please find out if you don't know who it is who's submitting your data. All of the hospitals in HIN are reporting to SDAHO claims-based data. So that is something that is currently happening and has been happening for, I don't know, Kathy, years. And so,
yeah. Yep.
So that
nearly
is
20.
Okay, 20. So that's something that is very beneficial to know who that person is. If you're working within a system, there's likely a system person who is submitting that for on behalf of your facility. So just understanding that process. The other thing that, and Kathy, you can certainly jump in to this, is claims-based data. When you're looking at claims-based data for quality improvement, it is different than data collection that you go out and collect. So I think that's important to bring forward. There's opportunities around how people enter in claims, what they're documenting, and so forth. So really understanding your claims-based data that's available out on the HIN dashboard, and starting to ask questions about how that's impacting or how it can impact is really, it's different. And so we just want to raise that understanding how people are submitting claims is important when you're looking at claims-based measures. We all know that CMS is moving towards claims-based measures, so we really want to give opportunity for our critical access to really get involved and understand how claims-based measures work.
Very well said, Kristen.
Does anybody have any questions for Jen or Kathy? This has been very helpful.
This is Kathy, and I have to duck off for another call, but I want to tell the people thank you for your hard work. It does mean improvement for patient care, and the value that you bring is immeasurable. So thank you for your hard work.
Thank you very much, Kathy. We appreciate you being on the call today.
Thanks, Kathy.
All right, so we are going to go ahead and move on. We're running a bit ahead of schedule, so we're going to go ahead and just finish up. This is the last presentation, HIN 2.0 wrap up and HIN progress. So I'm just going to talk a little bit about the history of the HIN. HIN 1.0 and 2.0 were CMS contracts through the Innovation Center. 1.0 went from 2012 through December of 2014. 2.0 September 2015 to September 2016. And now with HIN, we are looking at a 2-year base period and a 1-year option year or a 3rd option year. So potentially September 2016 through October 2019. IHC HEN campaign results. So this is a combination of HEN 1.0 and 2.0 results. This is 2010 through, looking at data that's 2010 through 2015. Total events avoided were about 4,700 events. Length of stay reduced was a little over 20,000 days. 41 lives saved, and over $63 million in savings. And this is just for the IHC HEN in 1.0 and 2.0. And we had anywhere from 110 to 127 hospitals. Now, HEN-wide campaign results, which includes all 3,700 hospitals that were included in the HEN work and all of the HEN contractors. 2010 through 2015, from 145 per 1,000 discharges to 115 harms per 1,000 discharges in 2016. So we've seen a 21% reduction in overall HACs. In 2010 through 2015, we saw $4 billion in savings from 2011 to 2012 combined, $15 billion 2013 through 2014 combined, and almost $9 billion from that last year in HEN 2.0. So over $28 billion in estimated associated cost savings due to the HEN 1.0 and 2.0 campaigns. And then again, an estimated 125,000 lives saved for the work that our hospitals did throughout the HEN. So what is HIN? You're all very well aware of what the Hospital Improvement Innovation Network is. We're engaging hospitals, providers, and communities to implement and test best practices, and we are committed to fostering a culture of safety and reducing harm. And also, we collaborate a lot with and support our QIN QIOs through education and engagement of acute care hospitals. We work very closely, the Compass HIN, with Telegen QIO, QIN QIO, on several different initiatives within the state of Iowa and Illinois. And then Sadaho works very closely with Great Plains there in South Dakota as well. So for HIN, there's a bit of a change in the goals. Once again, in 1.0 and 2.0, it was a 2040 goal. Now we're looking at a 2012. So 20% reduction in all-cause patient harm rather than preventable harm, and a 12% reduction in 30-day readmissions. Here's a nice infographic of the HIN focus areas that we're looking at the next several years. CLABSI, CAUTI, readmissions, of course, falls, worker safety, sepsis, C. diff, and I'm not going to go through all of them there. But then we have our several additional optional measures, which include your worker safety, undue exposure to radiation, and your MDRO and antimicrobial stewardship work. Data sources, as Kathy has mentioned through some of her previous presentations earlier today, we have 3 typical data sources for the data that we receive from hospitals. We have our statewide database, or the IPOP, that is submitted to the Iowa Hospital Association by all Iowa hospitals and South Dakota hospitals as well. We pull HAI data, which includes your CAUTI, CLABSI, SSI, VAE, and C. diff data from NHSN. So this is submitted by hospitals directly to NHSN, and we pull that on or around the 20th of every month from NHSN and populate that into the Compass HIN reporting database. And then additionally, we have our self-reported data that hospitals self-report directly to the Compass HIN database. All data is due 45 days from the end of the month. So right now we're looking at August 15th being the due date for June data. So by August 15th, you should be looking at making sure your June data is entered in. We have several different on-demand reports that are available within the database. One of those being the run charts. These are customizable, so you're able to pull for specific time frames if you only want to look at a few months, if you want to look, especially for all of you on the line today, for your claims-based measures. They go back several years, so you can look at trends over several years. Your self-reported data, many of you started reporting in December, January, so we'll only include data through that time frame. Within the run charts, we have the hospital rate per month. Here you can see that in this little table below the run chart. The state average, which is actually the HIN average, and that verbiage is being changed within the database. And then what your hospital numerator and denominator data that was entered or pulled from IPOP or NHSN and populated within the run chart. Also within the database, you have goal reports. These again are customizable. You can pull them on demand. Any data that you enter into the database, self-reported data, as soon as you enter it into the database, it is available within these reports. So looking at the goal reports here, really what they are used for is to look at your percent changed or your percent improvement. And that's looking at baseline to your current performance. Keep in mind for a lot of your self-reported measures where we don't have baseline data, you're not going to populate a percent changed. But we do have the ability to go back and try to help you figure a baseline and look at your percent changed from the earliest data that we do have available for you. So if that is something you need assistance with when you're looking at your goal reports or when you're looking at your dashboards, let Jennifer or Kristen know, and they can help you calculate your percent improvement or your percent change. So again, within the goal reports, you have your baseline start and end month, your baseline numerator. So that is, for most of the measures, that is a 2014 baseline. So for your IPOP measures, that'll be available within the database. And within the goal reports as well. So you have your baseline numerator, which is for that entire 12-month period of time. And again, your baseline denominator for that entire 12-month period of time. Your performance numerator and denominator is based on the performance period that you choose when you populate these reports. So you can choose, again, the time frame. I typically would look at a 3 to 6 month time period. So as you enter more data in, you'll be able to pull that 6 month time frame. For right now, I would look at that 3 month time frame. So your performance numerator and denominator will include just that data from that specified time frame that you enter in when you're populating these reports. The multiplier is what's used to come up with the rate. You'll have your baseline rate and then your performance rate. And then what the percent changed is that is taking your baseline and comparing it to your performance and looking at whether you're improving or not improving or declining. So that's your percent changed. In dashboards, we went through these a little bit before. Just a few notes about these. So there was a recent change within the database, so that this first column here that says improvement is going to say HIN improvement. So for those of you that use these dashboards internally, The HIN improvement, or this first column, really is based on your HIN improvement. So I know a lot of the times when we look at a stoplight dashboard, you see red and you panic, especially your CEOs, your boards. They're going to see that red and they're going to say, oh no, what are we going to do? There's red on here. A piece of education to throw in there when you are sharing these dashboards is the red doesn't necessarily mean that you are doing poorly. You can still have a red and have a negative number. You can see here with that stat Narcan, you can have a negative number, but still be well below the peer average or the HIN average. All it simply means is from your baseline to your current performance period, you had a decline in performance. So that's something to definitely keep in mind when you're looking at these dashboards. The green means you're improving. You're improving and you've hit that HIN goal, that 2012 goal for your HACs and your readmissions. You have hit or you have exceeded that goal. Your yellow is you may have seen some improvement and you may be doing better than the rest of the HIN or your peer average, but you have not hit that HIN goal. So that's really what those colors are based on. Have you hit that 2012 improvement? So I do want you to keep that in mind. Then within the second column is your facility rate for the performance period that was that you specified when you populated the report. Your peer average, which is split into two separate groups. You have your critical access hospitals and rural hospitals, and those are one group, and then your rural referral and PPS or urban hospitals in the second group. So those are your two different peer groups. And then the HIN average, which includes all of the hospitals within our HIN. Kathy talked about the HIN dashboards and the value estimates. So I'm not going to go into a ton of detail here, but again, I just want to just reiterate what Kathy had said before. Events avoided or incurred, that negative number that's what you want to see. That's events avoided. So when you see that negative number, that is you're moving in the right direction. Value added with participation in HIN, education and guidance on MACRA and MIPS and the quality program, payment program, nationally standardized measures, and comparative data. So again, you have that comparative data that's available within those on-demand reports that are available within the database. We have dedicated staff for data analytics and value analysis. We have our data team here in Des Moines at IHC that is able to help. So if you have specific data questions or needs, please let Kristen or Jennifer there at Sadaho know, and they will work with us to make sure that we provide those additional services. With regard to your IPOP data, we, IHC, but it does not, but IHA has the ability to pull your patient level data. So if you are looking at a specific month or a specific measure and you have questions, you see a sudden spike in one of those months, or you're not understanding where certain events are coming from, again, let Kristen or Jennifer know. They will get in touch with Kathy here at IHA, and they will be able to pull that patient level data and send it to you. We have our virtual or on-site coaching with your improvement advisor, that is Jennifer Cock. So I know a lot of you have been already working with her. Most of you have been. She's been out to see you. You do have those virtual or on-site coaching opportunities, coaching calls, virtual events, where she can assist you with any of your needs. When we talk about a dedicated improvement advisor, it really is we tailor our technical assistance based on the needs of the hospital. So Jennifer can help you with process improvement tools, specific projects, finding resources, whatever that may be. You just need to let her know, and she would be happy to help you. Again, availability of on-demand reports within the database, and expert faculty to assist you with lean performance improvement, physician and leadership engagement, and data and informatics. We do have faculty on staff here with IHC and the Compass HIN that is able to provide that additional lean and process improvement education. They're available to come out to your, it's Sarah Pavelka is our faculty member for lean, and she's available to come out to your hospitals to work with you on specific projects. Maybe it's Lean 101 or lean training that you would like to do for your staff. But if that is something that you are interested in, please let us know. We also have a physician here, Dr. Don Klitgard, that is available to come out and speak with your physicians and leadership to talk about engagement, maybe provide some physician education. He does a lot of stuff with med staff to try to get them engaged. So that's also another option for you if you're in need of some additional assistance there. Resources available to all of your HIN hospitals. Again, I went through many of these, just a couple additional notes. Team Steps training. We have several master trainers on staff that are available to work with you and your staff on Team Steps tools within your organization. We also do have Teach Back training available as well. We can come out to your facility, or we can do a virtual event for your hospital to teach your nursing staff how to use Teach Back when they are working with your patients. We have a pharmacist on staff here at IHC that is also available to work with you and your pharmacy staff within your organization to help with any pharmacy engagement, antimicrobial stewardship, your medication safety initiatives, and also community collaboration and care transition support where that is needed. We have facilitated several care transitions or community collaborative meetings throughout Iowa with our several hospitals, and we are happy to do that with you as well if that's something you're interested in doing more with. Conferences and online learning opportunities, you guys know about all of those. They're available on Hinnovation. All the events are available on Hinnovation within the events, under the events tab. Our monthly office hours calls, quarterly What's Up calls. Those are just conference calls. Dr. Tom Evans, our CEO, jumps on those calls and provides a national update every quarter. And then our monthly communities of practice, medication safety, HAI, person and family engagement, falls, and readmissions. Also, we have Hinnovation, which is our primary communication source for our entire network. We just had a revamp just this last week, so if you have any issues or concerns or feedback around Hinnovation, please let us know. We just moved to a new platform, which has some additional functionality. It's a little bit more user-friendly. And so just to let you guys know, there are some resources and videos that are missing from the library. We are working with the vendor to make sure that we get those back on there. We send out our monthly HIN Huddle email that provides information about upcoming events, new resources or new posts that have been put on Hinnovation, and then of course our monthly drumbeat that I just want to give a shout out to the top 10 list that we highlight every month. There were several South Dakota hospitals on there, so congratulations. Keep an eye out on our top 10 list. We're highlighting different measures every month, different focus areas, and looking at some really want to celebrate those high performers in those different areas. So I want to move into our current HIN progress. This is based on data through March of 2017. So this is looking at performance period January through March of 2017. Our year one target, that is what we had proposed to CMS. That's where we want to be at the end of year one, which is coming up pretty quickly here. This is including all of our HIN hospitals from our entire network for the Compass HIN. So looking at adverse drug event rates, or adverse drug events, our self-reported rate, year one actual cumulative. So what we've seen, I'm sorry, this is based on data that's October through March, I apologize. So year one actual, our cumulative, we have actually seen a decline from baseline of 2014 until HIN, a decline in 33% for our adverse drug events. INRs, we have seen an increase 12.8%. So that is looking fantastic. We're really great to see that, that movement. Blood glucose, our target is a 20% reduction, and we have met that goal. We have hit that 20% reduction, just slightly over 20%. You'll see in that last column there that we're looking at average count reporting for that 3-month time period. So we have right around 149 hospitals in our HIN. These are the number of hospitals that are reporting consecutively for the 3-month time period of January through March. So our goal is to get all hospitals to have data entered for those different areas. There's some areas where, you know, for CLABSI, SSI, VAE, and then the optional measures that not all hospitals are going to participate in. But for the most of those, we want to get up as high as we possibly can, especially for these ADE numbers, the rate, INR, blood glucose, and naloxone usage. We want to get that number up to 149. We want to see all hospitals reporting those measures. So for statin naloxone administration, that is an area that we are working on now with our opioid guardianship project. We have actually seen a decline in 145% from baseline. So we're moving in the wrong direction. Statistical brief, this is the adverse drug event statistical brief. We have actually seen a 66% improvement in that. And that one is pulled from IPOP. CLABSI rate, not all hospitals participate in this. Many of our critical access hospitals, which affects several of you, do not participate in the CLABSI measures. We have proposed a 10% improvement, and we have seen so far a 16% improvement in the CLABSI rate. CAUTI rate, again, we have blown that out of the park with a 35.9% improvement. C. diff, we had proposed a 20% improvement by the end of year one, and so far we are not doing as great as we would like to, and we've seen a 14% reduction. Falls, this has been an area that has been really tough to move for the last several years, but we have seen a 5.4% improvement in falls for this this HIN year so far. So even though we had set a target for 20%, I am really proud of the 5.4% improvement in falls. It's been really tough to move. Pressure ulcers, we set a goal for 15%. Again, fantastic. We are at 78.7%. And sepsis and septic shock, this is looking at the outcome measure. 20% was our goal, and we have hit 65.6% improvement in sepsis and septic shock. Surgical site infections, SSI colon rate, these are pulled from NHSN. So again, not all hospitals are going to participate in these. There are a lot of critical access hospitals, smaller hospitals that do not do these types of surgeries within their organizations. So colon rate, we had set a goal for 15%, and we have so far seen a 13%, so we are almost there. We are well on our way to 15. SSI hysterectomy, we have seen a 58% improvement. Hip, we have slid back a little bit to 6%, and knee, 3.9% improvement. Venous thromboembolism, this again is an area where we want to see all hospitals reporting on, and we have seen, but even so, we have seen a 16.9% improvement from baseline. VAE, another area where the majority of our hospitals are not going to be reporting. For IVAC, we've seen a 27% decline, but for VAC, we've seen a 74% increase, or I'm sorry, improvement. With those, when you look at the average count reporting here, just like when I talk to all of our hospitals, especially our critical access hospitals, when you have that low end, so here we have the average count reporting 15, 17, 18 hospitals, any variation is going to greatly affect the improvement percentage within these calculations. And then moving on to some of the optional measures. This is why you don't see quite as many hospitals reporting for these. Hospital culture of safety or worker safety, not seeing as much improvement in back safety and back injury and needle sticks as we would like to. And same with safe patient handling. We have not seen improvement there either. Undue exposure to radiation for both abdominal, CT, and thorax. We have seen improvement in both of those areas. And then readmissions. We have stayed pretty steady with the national average right at, well, actually, our numbers are below the national average for actual rate. We're between 7 and 8%. So we're much, much below the national average for readmissions. But as far as our improvement across our HIN, it has been pretty steady right around baseline from 2014 to now. So that's something that we're going to be working on and reaching out to hospitals with regard to your readmission rates and seeing how we can support you in that work. So then overall, goal for estimated number of harms that we would like to avoid. Kathy mentioned these earlier. A year one target was 1,056 for harms avoided. We have actually exceeded that goal with a little over 1,300 harms avoided. Year one for number of lives saved, we would like to hit 10. We have hit that with 10.79. So just we've hit that goal, slightly over that goal. And then goal for estimated cost savings. Year one target is 12 million. What we've hit so far is a little over 7.2 million, but we are right on target for hitting that goal for year one. So I just want to give a huge pat on the back to all of you for all of the hard work you have done for HIN and for your patients, the contributions you've made to the improvement that you've seen here today. Thank you for your participation. Thank you for your comments, questions, suggestions. We really use that to develop our program and to make it successful going forward. So please keep those comments and suggestions and questions coming. We do appreciate those. So I'm going to go ahead and open up the lines for any questions, comments. We haven't had a lot of questions today, but I'm going to open it up for any questions that anybody may have related to the information that we've gone over today, or questions that you have come across with the HIN work the last several months. So I'm going to go ahead and unmute everybody. So the lines are open. Do we have any comments, questions, thoughts?
Jen, this is Jennifer Clark. Can you hear me okay?
We sure can.
Okay, perfect. I just wanted to thank you and Kathy for all the information. It's been very valuable. It's, a lot of things I think a lot of the hospitals and I have talked about, but it's a really great refresher. And it's just nice to see all the resources that we have with our partnership. So thank you so much.
Thank you.
Okay. So they're charging us $75 an hour.
Do we have any other questions or comments? All right. Well, I am going to give you guys all back 45 minutes to your morning. So huge celebration there. We went through things quickly at a good pace today. All of the slides will be available on Hinnovation. We'll get those posted, and we will also get the video recording for this event on Hinnovation as well. So it'll be accessible to anybody that wants to go back and listen. If you have any questions after the event, please feel free to reach out to Jennifer or Kristen or any of the Compass HIN staff, and we would be happy to answer any questions that you might have. So again, thank you everybody for your participation today and for your participation in the HIN, and we will see you all again soon. Thank you.
Thank you.